Recognizing Impairment in the Workplace. This 2-hour training satisfies the requirements by the Florida Board of Nursing for education in recognizing impairment in the workplace. There are clear laws and regulations regarding controlled substances and impaired nurses. When you work in long-term care, every day is a balancing act of following the rules and taking care of people. I've always been a believer that your main objective and motivation for any decision-making should be taking care of the patient first, sometimes despite the regulations. This is true for patients and staff. If you come from a place of compassion and empathy, then you should be doing okay. These are the learner objectives. But what I want you to take away from this session is an understanding of addiction in our patients and staff, and realizing the grip and struggle people are dealing with and how to be a resource for them to recover, while complying with all rules and regulations. At the end of this program, we have listed resources and guidelines that are available if you want to go deeper into any specific area. Examples of opioid-controlled substances. These are C2s. Dilaudid, methadone, Demerol, OxyContin and Percocet, fentanyl, and all types of morphine. These are drugs of choice that are highly addictive and should be a red flag. These are drugs that should make your antennas go up when you see the prescriptions. You should question them. They're also drugs that the DEA questions and monitors closely. Every pharmacy at the end of the working day sends a report to eForce in Florida that reports the dispensing of all of these drugs. This is the latest statistics from the National Institute on Drug Abuse, NIDA, which is part of the National Institutes of Health. Roughly 21% of patients, or 3 in 10, are prescribed opioids for chronic pain, and they misuse them. 3 in 10 people that get hydrocodone misuse it when it is prescribed for them. You get a prescription for Vicodin after dental work, and soon you find yourself wanting to take more of this specific drug. Many opioid prescriptions are not prescribed, but diverted, using a friend or family member's drugs. Between 8 and 12% develop an opioid use disorder. 4 to 6% who misuse prescription opioids transition to heroin. Opioid use disorder is non-discriminatory and affects all socioeconomic groups. Age, sex, race, there's no pattern. About 80% of people who first use heroin misused prescription drugs. Let's say that again. Those people that are currently misusing heroin misused prescription drugs. Opioid overdoses have increased 30% from 2016 to 2017 in 52 areas in 45 states. The crisis has started in West Virginia and Minnesota, and even urban Florida, is now moving west to Colorado, New Mexico, and the Midwest. The Midwest saw overdose deaths increase over 70%. Here are some grim statistics. 130 Americans die each day from overdosing on opioids. This is 2017 data, which is the latest available. In 2017, more than 47,000 Americans died from opioid overdose. Let's try to put this in perspective. 58,000 soldiers died during the Vietnam War, a 20-year period from 1955 to 1977. So it can be safe to say that the opioid crisis is worse than having a Vietnam War every single year. 2 million people have opioid use disorder. That's 1 in 20 people. So if you have 100 employees, it's possible 5 people have an opioid use disorder. 591,000 have heroin use disorder. And at least 1 uses of heroin. Heroin is on the rise because of restrictions on opioids. When you limit the prescriptions, you increase the use of street drugs. In 2015, 20,000 people overdosed due to heroin and fentanyl. And again, heroin and fentanyl are increasingly becoming the drugs of choice for those who cannot get prescriptions for opioids. The peak of opioid prescriptions was 2012. Since then, you can see there's been a decline in how many prescriptions have been written. On the right-hand side, we see admissions for substance use treatment in publicly funded facilities. This is because laws are being passed across the country to help those that have opioid use disorder and help them find a path to becoming clean and sober. This is the overdose deaths that you can see that are increasing until 2017. It's a graph for what it's worth, and it's using the latest data. Heroin and fentanyl are synthetics and are increasing and more deadly, also due to the limits on prescription drugs. So what exactly is in heroin and fentanyl and opioids? Well, this is the history of opiates. It's as old as time. Since the earliest civilizations, societies have been faced with balancing the medicinal properties of opiates and then treating the euphoric effects that have induced its misuse and abuse. Do you remember that scene in The Wizard of Oz where they're going to the Emerald City and on their way they're running through poppy fields? What happens to the group as they're running through the poppy fields? Well, the Lion, the Scarecrow, the Tin Man, and even Dorothy fall asleep. This is because of the poppy seeds, which is the derivative of morphine and codeine. What we do know, it's been a problem since Mesopotamia that needs 2020 solutions. Why are opiates so addictive? This is a question that many people struggle with, especially family members and friends of those that are addicted. Opioids can make your brain and body believe that the drug is necessary for survival. It begins with a happy, mellow, no hangover effect taken by one pill, and it quickly turns into needing more medication to achieve well-being or to feel normal. As your body learns to tolerate the dose you've been prescribed, you need more medication to achieve just your own well-being. This is what leads to dependency. Addiction takes hold of our brains before basic needs of food and rest. How long do you think it takes to become addicted to an opiate? In as little as 5 days, a patient can become addicted to the drugs. And how long after you stop taking opioids do you think your brain can rewire and stop the cravings? It takes at least 18 months for your brain to be rewired, and some say up to 5 years. This is an example of how you diagnose opioid use disorder, OUD. It's a brain disease. Many people say, why can't they just quit? They don't understand why or how other people become addicted to drugs. They may mistakenly think that those who use drugs lack moral principles or willpower, and that they could stop using their drug use simply by choosing to. In reality, drug addiction is a complex disease, and quitting usually takes more than good intentions or a strong will. Drugs change the brain in ways that make quitting hard, even for those who want to. Fortunately, researchers know more now than ever about how drugs affect the brain and have found treatments that can help people recover from drug addictions and lead productive lives. Medication treatments can work best: methadone, Suboxone, or Vitrol. They block the euphoric effects of opioids and reduce the craving, but it is still a scheduled drug. This medication-assisted therapies should be taken for at least 18 months, and many patients find they have to take it forever. Also, it should include psychological services and group counseling. Many times, childhood trauma can be in a person's history, and that needs to be addressed. Let's look at some of these famous people who have died from opioid overdose. Van Gogh, Prince, Tom Petty, Mac Miller, Heath Ledger, Chris Farley, Kurt Cobain, River Phoenix, John Belushi. Here's a poll I'd like Let's take a poll. Who knows someone that's been addicted to drugs? Do you know someone that's died from an overdose or had an overdose? Do you know someone that's had a DUI? Have you ever suspected a coworker of taking drugs? Have you ever had a patient that was seeking or withdrawing from opioid drugs? Today's addicts crossed every socioeconomic group. The grip of opioid drugs is non-discriminatory. I am confident that after this poll, everyone would have their hands up after these 5 questions. My first patient that was withdrawing from drugs was about the year 2000. A friend's grandmother came to our facility after a fall. My friend called soon after her admission and told me her grandmother was desperate for her Xanax, a medication she had taken for years, and for some reason was not included in the hospital discharge orders. I learned very quickly that withdrawing from Xanax can be fatal. It was my first introduction to elderly that may be patients seeking or withdrawing from drugs. What is the definition of substance abuse? This is from the DSM manual, which is the Diagnostic and Statistical Manual. If two of the following have occurred in a 12-month period, the substance is taken in a larger amount or over a longer period than intended, and persistent desire or unsuccessful effort to cut down. Craving or strong desire or urge to use. Recurrent use resulting in failure to fulfill obligations at work, school, or home. Continued use despite having recurrent social problems. Important social, work, or recreational activities are given up. Recurrent use of the substance in situations in which it's physically hazardous, such as working or driving. Use of the substance continued despite physical or psychological problems. You want to quit, but you just can't. Tolerance, which is the need to increase the amount for the desired effect or diminished effect. And finally, withdrawal. Withdrawal symptoms or substance taken to avoid withdrawal. So if you realize once you stop, you go into withdrawal. Here's a case study. Isa was the 7 to 3 nurse on the rehab unit at Floridian Nursing and Rehab. Nancy, the 3 to 11 nurse that had volunteered to work 11 to 7, gave her report and then stayed to finish her documentation. When Isa did her morning rounds, she entered Mrs. Blaine's room. "Good morning, Mrs. Blaine. How was your night?" Mrs. Blaine immediately responded, "I need a pain pill. I can't stand the pain," and was noticeably uncomfortable. When Isa checked the MAR, it indicated that she received Dilaudid 8 mg at 6 a.m. When Isa returned to Mrs. Blaine's room to explain she had to wait for her next dose, she noticed she was moaning and writhing in pain. She gave Mrs. Blaine a few extra strength Tylenol and a quick back massage to help her relax. Isa gave Mrs. Blaine her dose of pain medication as early as indicated, and she was comfortable within the hour. For the rest of her shift, Mrs. Blaine's pain was controllable. As Isa documented that day, she noted several other patients had orders for Dilaudid because of severe pain from the night before, taken by Nancy. That afternoon, Nancy was back to work for 3 to 11. Nancy was late and disheveled and explained that she had a hard time sleeping after she worked a double last night. When Isa reported that Mrs. Blaine seemed to have uncontrollable pain that morning and reminded her to monitor the situation, Nancy became defensive. Isa got the feeling that the increase in pain medication orders and Mrs. Blaine's complaints of pain may indicate a diversion of drugs. Later that week, Becky, the consultant pharmacist, came to visit. Isa mentioned her suspicions about Nancy and the Dilaudid. When Becky checked the automated dose machine, she noticed that Nancy had multiple overrides in the past week for pain medications. Becky reported her conversation with Isa and the overrides to the facility administrator, Anne Marie. Anne Marie was shocked when Becky suggested that Nancy may be diverting drugs. "Nancy is my best nurse. She works any shift we ask. She comes early and stays late. She is devoted to this place." Despite her feelings, Anne Marie asked Nancy to meet, and she quickly confessed that she had taken the drugs. "My daughter is addicted to drugs," Nancy pleaded. "It will never happen again." After Anne Marie spoke to Human Resources, she explained to Nancy that if she quit, they would not report the theft. Nancy quit her job and was hired by another nursing home in the community. What are the red flags? The patient was in pain, and the pain was easily relieved once she got her medication. Dilaudid 8 mg, that's a drug that is on the DEA list as being one that is often diverted. Several other patients had orders for that same drug. Your antennas should go up. Nancy was late, disheveled, worked a double, became defensive. There's always a story, and when you are suspicious, you need to follow through with those suspicions. The consultant pharmacist saw multiple overrides. And finally, Anne-Marie, the administrator, said, "Nancy's my best nurse. She comes in late. She comes in early. She stays late." Well, this also is the sign of a good employee, but also it may be a sign of a nurse that is diverting drugs. And what did the administrator do wrong in the end? In the end, she let Nancy quit without addressing her diversion of drugs, and she was then hired by another nursing home, continuing to divert drugs, and her addiction is not being addressed. Nurses and addiction. Nurses are caregivers, and it is many times difficult for them to ask for help. They're used to providing care, not receiving it. About 1 in 10 of all nurses may be impaired or in recovery from alcohol or drug addiction. While this is consistent with the general public, if you have a staff of 30 nurses, there's possibly 3 to 4 nurses that are currently struggling with addiction. And although nurses aren't at a higher increase of risk than the public sector, they do have stress of the job and also the ability to access drugs that make them at a higher risk. Their pattern of dependency is unique because they also have the access to the drugs. Here's another poll. How many here do not have drug diversion at your facilities? Well, if you said your facility has no drug diversion, it's possibly because you're not looking. In the 2019 article, Diversion in the United States in Healthcare IT News, it states that facilities that seriously look and put an effort into surveillance always find diversion issues. The way that you can address these issues is ongoing detection and a surveillance program. Otherwise, a significant diversion problem can evolve for years undetected because it was never investigated. The facility itself is not immune from the risks caused by impaired nurses. There can be costly investigations, lost revenue from drugs that are diverted, poor work quality and absenteeism, survey citations, loss of your rating, being sued civilly, and ultimately a damaged reputation. Opioids are not the only drugs that are diverted, although they are the most common. Other drugs that are diverted include depressants, Zyprexa, Seroquel, and Haldol, stimulants such as Ritalin, Adderall, Dexedrine, and anabolic steroids. The DEA has its own drugs of interest. It's called the Top 4 DEA Hit List. And all of these drugs received special attention. Oxycodone 15 and 30 milligram tablets. Oxycodone APAP 10, 30, 325 tablets. Hydromorphone 4 milligram and 8 milligram. Hydrodone with APA 10, 325. Methadone 10 milligram, and morphine sulfate. Remember, when you see these drugs, your antenna should go up just like the DEA's. Upon receipt of an IPN referral, IPM initiates a consultation with the impaired nurse, and they provide an intervention, and the nurse must stop practicing within 1 to 3 days. They're assisted in obtaining appropriate treatment, including inpatient treatment if that's what they need, and also therapy and group sessions. They're continued to evaluate their progress, and they are monitored for up to 2 to 5 years.